We first have patients accurately with an accurate diagnosis, establishment of prognosis using the IPSS diagnosis or the DIPSS prognostic score throughout the course of the disease, as well as symptom assessment. We then stratify the treatment really based on risk, with low risk stratifying them between symptomatic and asymptomatic, intermediate 1 risk, intermediate 2, and high risk. We weave in our current approved therapy of ruxolitinib at each level depending upon whether a patient is symptomatic in the low and intermediate 1 phase, and then in all patients with intermediate 2 or high risk. We weave in the potential of allogeneic stem cell transplant, specifying in intermediate 1 risk in patients it's an option, in those that have high risk molecular features, or it's a strong consideration in those in intermediate 2 and high risk depending upon the status of the patient, the risk with the disease, the availability of a donor. And then we also try to stipulate the potential role of clinical trials at each of the stages.